Welcome to this PCR webinar on renal denervation for treatment of hypertension, heading for new shores. My name is Felix Mahfoud. I'm working at the Zeller University Hospital in Homburg, Germany, as a cardiologist and interventional cardiologist. And I'm very pleased to welcome three colleagues and friends here with me today. Atul Pathak from Clinique Pasteur in Toulouse, France, who's working there as an hypertension expert and pharmacologist. Atul.
Hello, Felix.
Tsioufis from the University of Athens, who's working there as an interventional cardiologist and who's also the current president of the European Society of Hypertension.
Hello, Felix.
And Thomas Zeller, who is a cardiologist, an interventional angiologist working at the University Heart Center in Freiburg-Bad Krotzingen in Germany. Welcome.
Hello, Felix.
Why are we here today? I think that is a very important question. Renal denervation is back on stage. We have a trial that has been published last year in The Lancet and presented at the European Society of Cardiology, the sham-controlled spiral off medication trial, a very important trial that we will discuss later during this session. But we're also here because two other trials will be presented just here in Paris in 2 weeks from now at the Euro PCR meeting. So research is pressing on and we have a lot of things to discuss. And I would want to know, before we start, from you guys, why are you excited about the topic? Why do you think we are sitting here? And I start with you, Kostas.
Being also a hypertension specialist, I am here, I am excited to appreciate the need of device-based therapy for the therapy of hypertension in light of the revised blood pressure goals.
Excellent. Thomas, any thoughts there?
Well, basically, since the publication of HTN3, we did deeply revisit the strategies how to perform renal denervation. We did some changes in the device technologies, and this resulted in a change of the treatment paradigm, going away from proximal renal artery treatment more to the distal segment of the main trunk and even into the segment arteries. And this is what I'm very interested in, to see how this now translates into clinical practice.
Atul, same question for you.
Yes, well, I'm really excited since the release of the spiral off data, and I really want to share our thoughts and comments with the audience and trying to move forward. What can we do with this data? What can we do with this clinical evidence in our practice? How do we reappraise the knowledge about the therapy? So really excited to share this information with friends.
So we agreed on certain learning objectives, obviously, for this webinar today. We want to appreciate the need of device-based therapies in light of revised blood pressure targets. But we also want to review revised technical and procedural aspects of renal denervation. And finally, we want to understand the current path of renal denervation and where we are moving with the field. I would want to pose the first question to Kostas. Kostas, before we talk about the need of device-based therapies for hypertension, there are many news around with respect to new treatment goals. The Americans just published their hypertension guidelines. Can you comment on this and put it into perspective for the audience, please?
Blood pressure targets remains a matter of debate for many, many years. We have plenty of data that reduction of blood pressure results in a significant reduction of cardiovascular risk. In light of the SPRINT study, at least at first glance, provide evidence that intensive blood pressure reduction translate in a huge cardiovascular event reduction, 20% reduction in the primary endpoint and 40% reduction in the cardiovascular death. Important clinical meaning. Also, we have important meta-analysis provide evidence that the greater the systolic blood pressure reduction, the greater the cardiovascular risk reduction. Based on this data, the American guidelines suggest lower targets of blood pressure. For all, less than 130 for systolic, less than 80 for diastolic, irrespectively of vascular status or age. Also, an important message of the American guidelines and also a point of criticism is the new definition of hypertension. We appreciate here in the screen the new definition of blood pressure, of hypertension. Those that we defined as pre-hypertensive or having high blood pressure in the previous guidelines high normal. Now they named as hypertensives. Hypertension is defined when office blood pressure is greater than 130, greater than 80 for diastolic. And based on this definition, if someone has stage 2 hypertension, definitely we will start antihypertensive therapy, additionally, of course, to lifestyle change. This is also in case for those with stage 1 hypertension, 130 to 139, 80 to 89 for diastolic. If they have increased cardiovascular risk, according to American guidelines, we have to initiate antihypertensive therapy. Of course, the European guidelines is under preparation. In the next meeting in Barcelona, we will have the opportunity to see what the new guidelines will say about this topic.
So you provided a lot of numbers, which are certainly important. But what is, in a nutshell, the most important change that you expect also from the European guidelines? Is it the lower blood pressure target?
Yes, this is definitely the answer. Since we have the data from large meta-analysis that the lower the blood pressure, lower than 130 for the most of the patients, the greater the cardiovascular benefit. I think that the message is clear. We have to go close to 130. But we have to take into consideration that the greater the systolic blood pressure reduction, the greater the cardiovascular benefit, but also for the patients at the population level. But for then one individual patient, we have to take into consideration that maybe the risk of side effects of antihypertensive drugs is increased, and also the rate of discontinuation. So we have to find an optimal target for safety and efficacy.
I could imagine that many of you are thinking about the U-shaped curve or the J-shaped curve. Atul, can you comment on this? So should we lower all patients to very low blood pressure targets, like 120 or 110? Is that beneficial for all?
Yeah, I think the question for the audience is the lower the better? I think there are three very short and quick answers. First, the epidemiological data shows that there is a linear trend. The lower the blood pressure goes, the lower the risk for the population. Second, interventional trial, for example, the SPRINT trial, show that if you lower blood pressure aggressively, you are able to lower the risk of event. And this led to the American guidelines Kostas have been through. And finally, if you look at the European guidelines, they have taken into account this risk, where if you go too low, for example, in a patient with coronary heart disease or in an elderly patient, well, then you might increase the risk of event. That's what we call the G-curve phenomenon, where by lowering blood pressure too much, you might increase the risk of adverse events.
And where's that starting, this lower blood pressure cut even, where increase starts again?
Yeah, so it starts really when you go below 120, sometimes below 110 for systolic blood pressure, below 80 and even below 75 for diastolic blood pressure.
So we're getting into a blood pressure window. Okay.
Yeah. But if I can add, Felix, what I agree absolutely with what Atul said, but particularly for elderly, if you have an 85 years old, I think we have to pay attention how low to reduce the blood pressure, systolic and diastolic. In these patients, you have to take into account how frail is this patient, not only what is his age, but also what is his biological status in order to find the appropriate systolic blood pressure target.
Thomas, how do we get patients controlled? I mean, we're talking about millions, probably billions of new patients with hypertension around the world. How do we get these patients controlled? Which tools are currently being used?
Well, basically there is not that much new on the horizon and not available for treatment. Backbone is still lifestyle modification. That's the first step. If we are confronted with a patient newly diagnosed with hypertension, and of course it's drug therapy. And there's no new drug available, but the focus is more on the combination pill. That means a fixed combination of 2 or 3 different kind of antihypertensive drugs, which should improve overall the patient compliance. And what's the background of the webinar today is basically that we have a device-based treatment modality. This also includes so-called e-health modalities like remote recording systems, but potentially also devices for managing sympathetic overdrive and renal denervation devices are one of those potential technologies we are going to discuss during the next couple of minutes.
I mentioned it before. We have the opportunity that you actually ask questions to us here, and we are getting the first questions from the audience. And I'm posting the first one, which is actually today in 2018. What is the gold standard for blood pressure measurement? Who wants to take that question?
If I can start first, according to the current guidelines, the European guidelines, but also to the American guidelines, blood hypertension is defined based on the office blood pressure measurement. And this is clear because we have many data from prospective randomized trials that reduction on office blood pressure results in a significant reduction of cardiovascular events. Of course, we know that blood pressure is a biological parameter with huge variability, and out-of-office blood pressure measurements provide significant information. Actually, the American guidelines recommend confirmation of office blood pressure with out-of-office blood pressure measures. But this is not so practical, it's not so feasible, and also there is no data to support that we can guide our antihypertensive therapy based on out-of-office blood pressure measurement. So careful measurement of office blood pressure is the key.
Okay, so that's an important recommendation from the European Society of Hypertension president. Measure office blood pressure, do it right, but this is still the way to go.
Yeah.
Next question is actually a very good one, and it's coming from Greece. And the question here is, are these guidelines easy to implement in daily clinical practice for non-hypertension experts? We discussed that there is a certain window in which we have to bring patients. How can we bring patients into this obviously very tiny blood pressure window? Who wants to take that question? Atul?
Yeah, I can take it. Yeah, I think that this is an issue. I mean, how to implement guidelines into clinical practice. What we know from clinical trials and from epidemiological data has been just summarized by Kostas and Thomas Zeller. But how do we change our clinical practice? I think first, number matters. So if we see a patient who is not at goal, you need to lower blood pressure by using lifestyle modification, drugs, and sometimes things beyond drugs. Second, we know that we have at least 3 drugs, RAS blockers, calcium channel blockers, and diuretics. You can start patient with these drugs, you can combine these drugs, and at the end of the path, you might be able to control almost all of your patient with the combination therapy of these 3 classes of drugs. I think this is really important. Third, try to follow your patient by measuring blood pressure and try to assess the complication of hypertension by referring these patients for the assessment of target organ damage. So I think the number matters. Try to control blood pressure with standard pharmacotherapy and follow up your patient and address them accordingly to be sure that they're not having a target organ damage.
Okay.
If I can add, of course, I agree that blood pressure numbers is very important, but also it is very important to estimate the total cardiovascular risk. Our purpose is to manage the patients in a holistic way. And hypertension is the single most important cardiovascular risk factor, but also the hypertensive patient has target organ damage, has ventricular hypertrophy, microalbuminuria, they smoke in 30%, they have a high cholesterol level, so we have to take all these parameters into account and also to spend more time to explain the importance of treating high blood pressure and to explain that maybe there are some side effects with the drugs, but the beneficial effects are too high.
So you are already referring to the problem of non-adherence, which is indeed a huge problem in treating patients with hypertension every day. And there's another question about new drugs in antihypertensive therapy in 2018, and is there anything in the pipeline? And I can probably take that one, as indeed the pipeline is empty. There's not much ongoing with respect to pharmacotherapy in hypertension. And given the fact that we have so many patients around the world who remain uncontrolled, the problems of non-adherence, the understanding that indeed hypertension is the leading cause or one of the leading causes for premature death worldwide, there is a huge unmet need. And this was actually the background for the development of device-based therapies. And this slide here nicely shows the different technologies and target areas that are currently being investigated. And you can see that we have devices that interfere with the baroreflex, carotid bulb expansion, for instance, and carotid body denervation, or baroreceptor stimulation. We have pacemaker-mediated antihypertensive technologies that are indeed under investigation now. We have a very mechanical approach to treat hypertension, an AV fistula, so where you create a mechanical connection of the arteria and the vein and the groin, and this lowers blood pressure. And we have renal denervation, which is probably the most popular and clinically most often used approach in hypertension. And this is the one that we want to discuss. But I think it is very important to broaden the vision a bit about the field. And we have a lot of sessions at this year's EuroPCR in May, where we will discuss all these topics in different sessions. But it's important to understand that this is an evolving field, actually, of interventional medicine. Atul, before we start the discussion about renal denervation, I would want to ask you how the patient population changed during the course of the development of the device. Could you elucidate on that one?
Yeah, there was a dramatic change, I would say, because we started to investigate the therapy in patients we called resistant hypertension, means patients who are not controlled with the standard triple therapy we've been through, patients who had 5, 6, 7 pills, who were so-called complicated hypertensive patients, uncontrolled hypertensive patients. These were the patients who have been recruited in the initial trials in the field. And we have seen, and we'll go through that, I think, later on, that slowly but surely we moved to patients who were having mild to moderate hypertension, where we tried to investigate renal denervation while these patients were on treatment, but also where they have been weaned. And these are the trials we call the off trials. So we really move from very complicated patient to very simple patient, from over-treated patient to almost untreated patient.
I know that many colleagues are asking themselves and have asked me actually, why have you started with the field in therapy-resistant hypertensive patients? And this is indeed a good question. Why did we start with the very complicated, severe, super sick patient population where nothing is working? Why should a neuromodulation approach work on those patients? Why did we start there?
The answer, Felix, is very simple. If you ask all those who attend our webinar, they are managing everyday clinical practice hypertensive patients. In one at least out of 10 hypertensive patients, they face this problem of difficult to control or resistant hypertensive patients. And we know from many trials that resistant hypertension or difficult to control hypertension is associated with 3 to 4-fold increased risk for stroke, for coronary heart disease, for heart failure. That this is the reason that always the medical community tries to provide the best therapy in those who are at increased cardiovascular risk. This is the huge problem, and unfortunately, despite the guidelines, despite all efforts, a huge percentage of hypertensive patients remain uncontrolled, remain resistant hypertensives, and this is the new area for interventional therapies.
Thomas, a comment on benefit-risk ratio as an interventionalist. Why did we start with these patients?
Well, that's obvious. That's clinical practice, that if you implement new device treatments into medical treatment, into medical routine, you have not only to test efficacy, you have only to look on safety. And if you are coming with new technology, you never know how safe the technology is. So you are looking for dedicated patient populations that are the ones who have no other option. Well, and basically what we learned from animal studies was that renal denervation based on radio frequency application seemed to be safe, but it had to be proven in a patient population in daily application. And this was the reason to select patients at high risk for encountering complications from their basic disease, which is uncontrolled hypertension, to expose them to the lowest peri-interventional risk possible.
Okay. So we almost talk about renal denervation as a procedure, but I think we have to also discuss how it works. In principle, you as a pharmacologist can probably address this the best. What's the pathophysiology behind renal denervation?
Well, I think, and this is maybe the link between our different intervention, resistant hypertension was characterized by an overactivity of the sympathetic drive to the vessels, to the heart, and it's a typical condition known to to be associated with a very elevated tone of the sympathetic nervous system. So it was a logical way to offer a therapy which was reducing sympathetic nervous system activity in this patient. Second, it's the way we do the development of devices. We always try with the most complicated patient, and then we move forward to the less complicated patient. That's the nice way to assess the benefit-risk ratio of a therapy. And third, but maybe Felix, you might comment about this, the pathophysiology behind the therapy and how it really works. Where does it act? Maybe you are familiar with the therapy and you've been a pioneer, so you could maybe share this with the audience.
So basically what the target is, or what we aim actually is, we try to modulate renal sympathetic nerve activity. And we well know that there are so-called afferent and efferent sympathetic nerves. The afferent nerves, they connect the kidney with the brain. They are so-called C fibers, sensory fibers, and whenever there is ischemia in the kidneys, you can increase central sympathetic activity by that upward flow. On the other hand, there are efferent nerve fibers which connect the central nervous system with many organs in our body, including the kidney. And at the level of the kidney, they are important for vasoconstriction. They induce vasoconstriction. They also increase renin secretion, and they retain sodium. So whenever these efferent nerves are stimulated, all these three aspects are being triggered. And the overall concept of renal denervation is that we modulate this activity, not only the afferent but also the efferent sympathetic nerve activity. And we have indeed good preclinical and a large body of preclinical evidence indicating that this is modulating sympathetic, thereby central sympathetic activity, and decreasing blood pressure in many animal models. And the question was, of course, is that transferring into human pathology also and pathophysiology? And that was the objective of the spiral off medication trial, which was a trial in uncontrolled hypertensive patients, a randomized sham-controlled proof of concept trial. And this is very important for the later discussion. This study aimed at assessing the principle of modulating sympathetic nervous system activity and thereby lowering blood pressure in patients with hypertension. And what was absolutely different compared to previous trials is the fact that in this trial, not severe treatment-resistant hypertensive individuals have been included, but patients at very low risk, so-called moderate hypertensive patients. No concomitant antihypertensive therapy was administered in these patients. They were either drug naive or considered to be at certain blood pressure levels where washout of medication could be performed. And the trial flow, the study design looks like this. You can nicely see that we had the screening visit 1 where certain blood pressure windows had to be met. There was a safety check after 2 weeks. And then there was a screening visit number 3 where the patient again was also had to be into certain blood pressure windows. It was for ABPM above 140 and below 170, and for office above 150, below 180. And importantly, we excluded isolated systolic hypertensive patients with a diastolic blood pressure above 90. These patients were then randomized in the cath lab. Sham control was the comparator here. So patients were indeed in the cath lab. They were sleeping. They had blindfolds on and were listening to music during the procedure. So indeed, the patient, when he or she woke up, was not aware of a treatment allocation. Sham control was the comparator, I mentioned that already, and renal denervation was performed in the other group, and you can nicely see that at 3 months the primary endpoint was collected of this trial, and this was mainly ambulatory blood pressure. The outcomes are depicted here. They have been presented at the European Society of Cardiology and subsequently being published in The Lancet. There was a significant reduction in the renal denervation group. This is shown here. As I mentioned, the primary endpoint was the ambulatory blood pressure. And this is here referring to 24-hour systolic blood pressure, indicative of the blue bars here. There was a 5.5 millimeter of mercury reduction in the renal denervation group, no significant change in the sham group. Probably even more important, there was also a significant drop in diastolic blood pressure by 4.8 millimeters of mercury. Again, no significant change in the sham group. And the intergroup change, the difference was statistically significant. The same, although of larger magnitude, was the change in office blood pressure, shown here on the right-hand side of the slide. You can see in the blue bars again the renal denervation group. The office systolic blood pressure reduction was 10 millimeters of mercury, 2.3 in the sham control group. The difference between two was statistically significant. And the same for diastolic, 5.3 millimeters of mercury, and no significant change for patients in the sham control group. Important findings, I think, because they prove that indeed renal denervation is working and it is lowering blood pressure in patients who are not taking antihypertensive medication. So this is the pure patient population to investigate, as pharma is doing with all devices that are being developed, a pure patient population where you can really assess, truly assess the effect of a device or a drug are those where no concomitant antihypertensive medication is prescribed. That is why I think these trial results are so important, because they confirm the overall concept. But I would want to pose that question, and a lot of discussions are ongoing about the magnitude of effect. So we have seen a 10 millimeter drop in the renal denervation group in office. Is that clinical meaningful? And I think that is also an important question whenever it comes to clinical application of a device. Is 10 millimeter office blood pressure reduction important? Who wants to take that one?
No question about the importance, about the clinical relevance of this blood pressure reduction. We appreciate in this very large meta-analysis published in The Lancet a couple of years ago that 10 millimeters of mercury reduction in systolic blood pressure translated to 27% reduction in the risk of stroke, in a huge reduction, 28% in the risk of heart failure, 13% in the risk of total mortality. This is very, very important with clinical meaning, clinical significance in terms of cardiovascular events. This is the reason why FDA has accepted that if an intervention, a medication, could effectively reduce the blood pressure, there is no need for outcome trial, because this blood pressure reduction will translate in cardiovascular protection. This was not the case, for example, for the anti-diabetic drugs. Not only to reduce, this is the difference. So no question about the clinical significance of this blood pressure reduction.
Any comments on study design? Thomas, I know that we had a lot of discussions in the past about sham control as the comparator.
Well, basically, I had some concerns, and I was not the only one, to expose a patient to the risk to undergo an angiographic procedure without treatment. So basically, the sham control means the patient is undergoing the same pre, peri, and post-procedural steps like the patient who was treated with renal denervation, but he did not receive renal denervation in fact. So the patient did not know whether he was treated or not. He received analgesics, he was sedated, so at the end he had no idea whether he was treated. And in addition, it was a double-blind study, so the operator was not involved into the follow-up examination of those patients. This was another group of physicians and technicians who performed blood pressure measurements. Those people had not been aware of which kind of treatment the patient did receive. So everybody was blinded, and what you already showed at 3 months, there was an unblinding.
I just wanted to add something, Felix.
Yeah.
I think that these trials in the field of renal denervation has opened the path. They've opened the path for the sham science. And this year we have been seeing the Orbiter trial showing that sham angioplasty was doing as good as normal angioplasty. The GOS trial showing that the placebo was having as much side effects as the normal treatment with the statin, and also the field of renal denervation. So I think the bar has been set up quite high, but it's needed to convince the community, to convince our audience that the therapy is working, because these trials have used something which is really new. And this approach with the sham procedures, I think, is really something important in terms of gold standard of methodology. There will be no other trials without the sham arm now, after what we have learned in the field.
Yeah, I like the comment by Atul about the similarities, renal denervation and the PCI in stable coronary artery disease. This is most important in the case of blood pressure with this huge variability. And we know from the pharma trials that placebo could result in a 5 to 10 millimeter reduction in office blood pressure or to 1 to 3 millimeter reduction in ambulatory systolic blood pressure. This was the case in the off-medication study. The SAM ablation reduced similarly to placebo the 24-hour systolic blood pressure.
So would you expect, if you use a device that has shown to reduce blood pressure by 10 millimeters of mercury in a sham-controlled clinical study, would you expect that to be larger if it's done in routine clinical practice, or would you consider it being the same or even smaller?
But my belief is that if you look at the variability of response, there are some patients who are super responders to the therapy and others who are not responding as well, but that's also the case in trials with drugs. But my belief is that it's a very interesting situation where probably in clinical practice, the clinical effect might be even more important than what you see in a clinical trial, because you know clinical trial are an artificial world where you try to control everything, which is not the case in real life. So you might even hope that if you offer the therapy in clinical practice, the blood pressure lowering effect might be even higher than that what we've seen.
You're bringing up a very important point, and there are questions coming up also about the patient preference and the patient population. Perhaps we can split that into two parts, this question. First question, what was the patient population that has been included in this trial? How is that differing from previous trial? And second question, what is the importance of patient preference in this context?
I think regarding the patient population, there was a big step forward because we decided to recruit patients where, as I told, mild to moderated hypertensive patient, mainly male, as usual in cardiovascular trials, and in this case in the spiral off trials. They were weaned off their treatment, so 1 or 2 drugs for hypertension were stopped before entering the trial to assess the pure effect of renal denervation. The risk factors were not so important in this setting, and they were slightly overweight. So I would say these patients who have been included in the spiral off trials were not the very complicated one of the previous trials, but they are really looking very similar to the patient we see in our daily practice. Those who are taking 1 or 2 pills, slightly overweight, having numbers 160/100 in their office blood pressure measurement. I mean, you know,
it's the me and you patient with hypertension.
Exactly.
Okay.
Exactly.
A patient preference? Short comment on that one?
Yeah, I think that this is also a very important point, because when you are referring to patients who are only taking single pills, and that's what we experience when we're doing these trials, a way to convince these patients, or why their wish was so high to be part of the trial, was mainly, I want to stop taking drugs, or I don't like side effects, or I believe that I can live differently with my disease if I'm not taking pills. So I think that these mild to moderate hypertensive patients taking 1 or 2 pills were really willing to be part of the trials because there was the opportunity for them to stop taking pills.
The colleagues who are online actually ask questions also about the procedure, and I think that is very important. We completely revised the whole procedural aspect of renal denervation, and Thomas Zeller, as an angiologist and interventionist, can you comment on the changes that have been implemented, the device that has been used, and you know what is really the revision and what has been worked over in the past on this one?
Well, basically, the technology that was used within the spiral trial was the same as in HTN3. It was radio frequency, but the device was different, and the technique of applying radio frequency anatomically did differ from HTN3. So what we can see here on this first slide is the radio frequency ablation points were located in the mid and distal part of the main trunk, as well as in the main branches. What means main branches? Every branch that had a diameter of at least 3 millimeters had to be treated. And this resulted in a much higher treatment number, meaning spots that had been ablated, as compared to HTN3 in the past. And regarding the technology, there's a short animation. We had been using the spiral catheter which was able to apply radiofrequency ablation at 4 spots in parallel. So due to its design, it was a more or less 360-degree ablation in one location, and this gave us more confidence that we could reach all the 4 quadrants in different areas of the renal artery. In addition, this resulted not only in new targets for the treatment, but also in a significant higher total number of ablation sites. What you can see here per patient, it's almost 44 ablation sites. The majority had been applied in the branches. So we went really distal, and the basis for this was the preclinical workup, where we learned that we are getting closer to the nerves and we are reaching more nerves with our ablation efforts. And by comparing this with what was done with the old device in hypertension 3, where we applied radiofrequency applications more proximal, it's almost 4 times more applications. So we did much more in order to reduce a sympathetic overdrive.
Thomas, this is, I think, a very important point that you are bringing up, because we completely changed the procedure. It's absolutely different from what we have done in Simplicity HTN1 and 2 and what colleagues have been done in clinical practice with the monoelectrode system. And there's also one question referring to it: is the treatment location for all devices the same, or do we have to come up with a distinct treatment recommendation for distinct devices?
Well, the data are only true for this dedicated radiofrequency-based renal denervation device. So we cannot translate the outcome results, the clinical outcome results, to other devices.
Important, yeah.
And in addition, the mode of action and how it should be applied does differ as compared to 2 other devices which are currently under investigation, under clinical investigation. One is using alcohol. This is a device which injects alcohol, 0.6 milliliter per renal artery in the mid or distal segment of the renal artery main trunk. So with this technology, you don't need to go into the branches to achieve a more or less circumferential ablation of the sympathetic nerves. And the same holds true for the ultrasound-based device, the Paradise system, which emits ultrasound in a predefined depth circumferentially around the renal artery. And this technology is also applied only in the main trunk, in the mid and distal segment for renal nerve ablation. So the kind of application of the renal denervation device depends on the device technology and design itself. But basically, what we learned is going back from the proximal part, from the origin of the renal artery, to the distal part of the renal arteries in order to more effectively ablate.
Because the nerves are getting closer to the
Exactly.
lumen. I think that is also an important comment. Kostas, and then Atul?
Based, Thomas, on your experience, how long does last all this procedure to go to ablate in every one of its branches? And also, based on your experience, how difficult it is to engage each one of these branches by using the spiral system?
Well, it's definitely true that not every device is useful or can be used in every anatomical condition. So this changes a little bit the pre-interventional workup. I would clearly recommend to perform a kind of angiographic workup, meaning MR or CT angiography, to be confident about the anatomical conditions and to clearly decide which device can be used and which is not useful in a given anatomical condition. Regarding treatment time, it's obvious if you have to go into the branches with a device, you have to wire these branches, you have to advance the system, you have to activate it, that this takes more time than simply apply circumferential ultrasound energy at 2 spots in a renal artery, go to the next renal artery, and after total 4 denervation cycles, you are done. So obviously, treatment time differs from device to device.
You had a comment also?
Just a quick comment. I think what we have learned from trials and as a clinical pharmacologist, no class effect for benefits. I mean,
Yeah,
and no class effect for risk. So every device has to go through this clinical path and show it's doing the right job in the right patient, and that the benefit-risk ratio is in favor of the therapy.
A colleague from Spain actually is asking if there's any role of renal denervation in patients with atherosclerotic renal artery stenosis. Thomas, that is your topic, I guess. Renal artery stenosis and renal denervation, controversial topic. Revascularization of renal artery stenosis, that would be another webinar, so we don't want to touch that one.
Yeah.
But can you comment on renal artery stenosis and renal denervation?
Well, basically, if renal artery stenosis is significant, this has to be shown by a flow reduction distal to the lesion, to the stenotic lesion. You can use FFR measurement, you can use duplex ultrasound to do that. So if this is significant, it has to be fixed upfront before you perform renal denervation. If this lesion is not significant, then you can decide to use renal ablation devices, because nowadays we are applying them at the distal segments of the renal artery, far away from the usually osteally located renal artery stenosis.
In any case, in the setting of clinical trials, all these patients have been excluded, so we don't have enough data to say more about that.
Another comment from you is, what about safety of renal denervation? This is, of course, a concern when we treat patients with mild to moderate hypertension, where obviously alternative treatment technologies are available, such as drugs or even lifestyle modification. So it becomes a concern probably for payers and insurance companies and physicians taking care of these patients. What is the safety of renal denervation? Who want to pick that one?
Well, I can do it because, well, I did a couple of hundred of those cases, and independently on the technology I personally have used and what is reported, there are only anecdotal reports that renal artery stenosis was detected after renal denervation. This was the major concern when we started applying radiofrequency to the renal arteries based on the experience we gained with pulmonary vein isolation. There it was very frequent that scar formation happened, resulting even in pulmonary vein occlusion. And this was not seen for all the tested renal denervation devices so far acutely and on midterm. What we don't know, and this has to be stressed, is the long-term effect of applying energy resulting in scar formation focally in the renal artery. Could that induce a kind of atherosclerosis on the long term? So this is very interesting, particular in this patient population studied in the spiral off medication cohort, because this is a young patient cohort and we don't know what will happen in 10 or 20 years.
But in this trial, at 3 months, there was no safety concern detected, but this is, of course, short-term follow-up.
And this is supported, by the way, by the GREAT study, by the registry, including the use of the same catheter system, and there we have a follow-up over more than 2 years so far. Also no safety concern, but this is midterm.
Absolutely, yeah. You had a comment, Kostas?
No, even the, let's say, not positive HTN3 study did not raise any concerns about the safety of renal denervation in terms of renal function deterioration or new renal artery stenosis. So,
okay, great discussions. What is, I think, and we have to move on with not only with our webinar, but also with the evaluation of renal denervation. So we have heard that off trial was indeed positive, so we have a signal that renal denervation is lowering blood pressure with the device that has been used in there. We are here in Paris now. In a couple of weeks from now, EuroPCR is taking place. There will be 2 important trials being presented. The spiral on medication trial, which was indeed a trial where patients with concomitant antihypertensive medication were exposed to sham or renal denervation, and we will learn with that trial whether or not renal denervation in combination with antihypertensive medication will also lower blood pressure. And there is another trial, an important trial, the RECORE Radiance Solo trial, where indeed the same patient population, pretty much the same patient population as the spiral off trial, patients who were drug naive or have been washed out, underwent renal denervation using an ultrasound device or sham, and we will learn whether or not this device is also lowering in that patient population. But for the field, it means that we aggregate data and that we learn more about the overall concept, the pathophysiology, and that we'll understand whether or not the devices have distinct outcomes. And this is something that we have to discuss for sure. But Atul, if you have to summarize now the outcomes of Spiral Off and what we're going to hear in a couple of weeks from now here in Paris at EuroPCR, what are your main comments on that? What do you foresee? What are the challenges? And what is the impact of what we will hear? Irrespective of that, we don't know what will be presented. But what is the take for you, and where do you see the field moving to?
I think first, thanks to the Spiral Off trial, we have learned that renal denervation is having what the authors nicely call the plausible biological effect. So it's a pure effect of the therapy, able to show in this trial, in this pure trial, with the gold standard regarding methodology, that renal denervation is indeed lowering blood pressure. I think it's a very important message for the community. The therapy is working. That's the way to set up the basement of the house we are building. The second step will be confirmation or not if in the same subset of patients, I mean the off patients, those who are not taking any pills, another therapy is going to work. And that's what we plan to see at the meeting, at the EuroPCR meeting, with the RICO Solo trial. Thomas Zeller showed us the technology, an ultrasound-based therapy. And we want to see if in the similar patient, where mild to moderate hypertensive patient without drugs, another therapy is offering the same effect, or maybe even a higher effect. And then,
or no effect.
Or no effect. I mean, that's the slide where we played with the hypothesis during the meeting you organized, putting all these investigators together, where we try to hypothesize what could be the future. And the third thing would be to move a step forward, now to these patients who are treated with 1, with 2, with 3 drugs. That's what we call the on trials, so patients who are on medication, and see of the therapy we've been talking about, the ultrasound-based therapy, the radiofrequency-based therapy, are able, again, to show a positive effect. So, confirmatory results and maybe a glimpse into the future.
There's a question from the audience. Can you identify responders versus non-responder previous or prior to exposure of the patient to an invasive treatment? And this is indeed one of the unmet needs that we're all thinking through scientifically. Can we identify these patients? And I think this question is so important that we have to respond to it now. Are there any thoughts about, the perfect patient for renal denervation at the moment? And are there any predictors available that could help us identifying these responders?
At the moment, we don't have, let's say, an accurate way to identify the responders to renal denervation. What we know from the previous studies, those with the higher the baseline systolic blood pressure, the better response to renal denervation. This is according to the phenotype. But on the other hand, now, after the positive results of the off-medication study, we could say that patients with systolo-diastolic hypertension, excluded patients with isolated systolic hypertension, patients without receiving antihypertensive medication or after was out of this medication, with confirmed hypertension, respond to renal denervation, and the renal denervation result in a significant and clinically meaningful reduction in systolic blood pressure.
But there is, we in the paper there is a fan plot, so that indicates actually each individual drop in blood pressure, and you can see that there were patients who had an increase, patients with a slight decrease, and patients with a huge drop in blood pressure. Any thoughts? And this is more scientific discussion. Any thoughts on how we could identify these patients, probably also with a new device or technique or any measure? Thoughts about this? I know that you're working on renal artery stimulation.
Yeah, this is a very interesting approach during the procedure or just before the procedure by performing mapping of renal fibers to identify, after a renal stimulation, renal fiber stimulation, those who will respond after renal denervation. But at the present, the results are very promising. And what is very interesting is to see that there is also a huge variability in the response to blood pressure after renal stimulation. This makes more difficult and more challenging the whole concept.
Short question. I'm taking a question from the audience, which is also a very good one. Indeed, patients who did not respond previously to the procedure, should we do it again? So in a non-responder, should renal denervation be performed again? Thomas?
Well, it depends on the patient condition. Well, what's the indication for treatment? If he is resistant to treatment, I would do it again, because this is the lesson learned before HTN-3 when we performed renal denervation as a standard clinical procedure. We had been using a different denervation system, and in my own experience, I would say more than 70% of those patients did respond using another renal denervation device after having had a failed initial treatment. So
but this is investigational.
This is investigational. We have no study-supported data. That's personal experience.
Okay.
Maybe a quick comment. Yeah? No, quick comment. Also, we have also the information coming by the expansion of data as we are offered from clinical trials, and there will be, and there was an announcement regarding a new trial which is going to be started under the agreement of the FDA, which is the Spiral Pivotal trial. And I think beyond experience, research, biomarkers, I think getting the right number of patients, because that's really the strength of this pivotal Spiral trial, where more than 400 patients will be recruited in a setting which is close to the Spiral off trial, but at least you are increasing the number of patients by almost 4. And I think by adding these data together, by getting even these clinical data, and by powering the data, getting a huge number of information will also allow maybe to identify maybe just simple clinical predictors of response, which are sometimes difficult to obtain because trials are usually less powered than till yet.
You're pointing towards a pivotal trial. Actually, this week, Medtronic, in agreement with the FDA, kind of released to the press that a pivotal trial is taking place now in Europe and in Japan, in the US and in Australia. And there, patients with hypertension, similar to the off-medication trial population, will be included. Over 400 patients to be enrolled. It's a sham-controlled study, randomized, it's powered, and that will, of course, provide a huge body of evidence, which is indeed important before we can draw any conclusions for the clinical use of renal denervation in practice. We're coming almost to an end of 60 minutes. We have a couple of minutes more left. I would want to take the one or other question from the audience before we summarize. And there's one which is indeed a very interesting one, which is talking about the sustainability of the treatment effects. So what do we know about the long-term blood pressure lowering effects of renal denervation, and how can we prove it? Short answer, please, and who's taking it?
Based on data from the Simplicity registry, we have data that those who are responders continue to be responders during the 3 years follow-up. This is a very promising finding, but of course we need more data in the future studies to confirm the long-term reduction in blood pressure.
How can you prove it with clinical studies, the long-term blood pressure lowering efficacy of renal denervation? Any thoughts on that one?
Well, my guess would be, because it's very complicated. We know, for example, that there is an amplification of the effect throughout times. We do not know if it's related to the fact that suddenly patients are starting to take the pills. So my guess would be to engage more the patient and make the patient a real actor of following up the effect of the therapy has been offered. And by getting information through this patient, where you can look at blood samples to know if he has restarted to take drugs, where he's giving you numbers he has collected at home. I think one way would be to make the patient a partner
of it.
and part of the research in order to help us to assess maybe in a better way the long-term effect.
But keep in mind that for patients with atrial fibrillation, a second ablation of pulmonary isolation of pulmonary veins increased the success of the procedure. Maybe if someone after 5 years or 10 years a second renal denervation may be an option.
That has to be proven still, but this is an interesting hypothesis at least. You were talking about atrial fibrillation, or at least touching upon it, and there's a question from the audience. If we suggest that we should pick patients with hypertension-mediated organ damage to be the especially right patient for neuromodulation, such as patients with retinopathy and patients with microalbuminuria. That was a question from the audience. A good one. Who's responding?
Preliminary findings also from my center, from your center, from other centers, shown that renal denervation has, let's say, pleiotropic effect, reduction in left ventricular mass index, reduction in microalbuminuria, even in the arterial stiffness, independently of the size of blood pressure reduction. This is very promising, but of course preliminary results that has to be proved through randomized clinical trials.
That was an interesting outlook into the future, the pleiotropic effects of renal denervation that have to be proven or disproven in clinical studies. We're coming almost to an end, and I would like to thank you first of all for being with me here and with us all here in Paris. And I would want to ask you each, what are your takes in 1 minute? What are your takes from this webinar for renal denervation? What is your summary in 1 minute? Kostas, do you want to start?
Yes, I could say that today we have the opportunity to reconfirm that there is a space, there is a room for interventional approach for the therapy of essential hypertension, additionally to lifestyle change, additionally to pharmacotherapy in some cases, in light of the new lower blood pressure targets.
Thomas, you talked about the procedure and about different devices. What is your summary there?
Well, my summary is, even if we can't compare resistant hypertension and drug-naive hypertensive patients in their response to renal denervation, it's for me at least important to realize that a critical review of our technique, how we apply a given treatment and modification of devices, did obviously result in a change of clinical outcome, meaning that opposite to HTN-3, where the interventional procedure was not superior to a sham procedure, now in patients without medication, going distal into the branches, applying more ablation points, does definitely result in a benefit in terms of reducing blood pressure.
Perfect. Atul?
Patient, patient, patient. Try to offer the therapy and take into account patient preference. Include patient in clinical trials to grow the evidence and the level of evidence, and probably engage the patient as a partner for long-term follow-up to assess the best benefit-risk ratio of the therapy.
Thank you. Yeah, dear colleagues, ladies and gentlemen, it was great to have you with us. We're coming to an end of an hopefully interesting discussion here at the PCR webinar, which was entitled Renal Denervation for Treatment of Hypertension, Heading for New Shores. We are indeed at a very important stage of the development of this field. EuroPCR is around the corner. A couple of weeks from now, we'll meet hopefully all of you here in Paris, where a lot of interesting data will be presented, and I look really forward to see you there. Thanks for listening, thanks for discussion, and all the best. Bye-bye.
Bye-bye.